If you're watching this video, it's because you are interested in conducting the upper limb tension test for the radial nerve. Hi, my name is Jody Roberts, and I'm an Indiana State University's Doctorate of Athletic Training student. It is my second year, and I'm excited to show this to you today. But first, an introduction. If you're watching this video, it is because you've already ruled out emergent situations having occurred to a person who's showing symptoms of some sort of neurological pattern, specifically for the radial nerve. If you have not done that at this time, I recommend you go to my suggested videos and watch Megan Kinzer's video on a full neurological screening. If you feel that you are in the right place and your patient is presenting radicular symptoms, so symptoms that are going away from the nerve root, and it happens to be a radial nerve pattern, please stay tuned. Another reason why a patient might be coming to you or you might be watching this film is because your patient has a history or is currently suffering from an injury that is bringing inflammation near the radial nerve, or again has a history that brought inflammation to the radial nerve, and now while later after maybe the initial injury is healed, they're still having symptoms. So we're going to talk about why that is and how nerves should work, and then we'll go into the tension test itself and how we diagnose a neurological tensioner. Before we get into the radial nerve, it is important that we first understand how nerves are supposed to work as a person is moving. So let's dive a little deeper into that first. If we were to look at this image and review a little bit of pertinent anatomy, we understand that a single axon is supposed to move freely within the myelin sheath. The myelin sheath is found within the perineuron. Those make up the different fascicles that are all grouped together and found within the epineuron. Now, it is important to understand that all nerve fibers should move easily within the fascicles, and those fascicles should move easily within the epineuron as a person moves. Anytime that our nerves are going from our spinal cord down to our extremity, crossing all these different joints in between, they're going to have to move with us. Otherwise, we would feel tight, not able to move. If we did move past that range of motion, if our nerves were stuck in one area, we would have different symptoms radiating down from the fixation. Now, that's important to keep in mind as we talk about our next subject. But first, let's talk about the radial nerve. Looking at this radial nerve, it is important to understand that the radial nerve, although it extends into your fingertips, begins at a place called the brachial plexus. Now, just looking at the brachial plexus, our brachial plexus comes from, it's a group of nerves, that are coming off of the nerve roots C5 through T1. Breaking those nerve roots down, they go into different trunks of the brachial plexus, which then divide into divisions, divide into cords, and eventually you get these different branches of peripheral nerves. The one we're going to be focusing on is the radial nerve. Now, the radial nerve extends down the backside of the arm. If we're talking about sensation patterns, it would look something like this. Notice that the back upper area of the arm is innervated by this nerve. Sensation then extends down past the elbow and pretty much the center, posterior aspect of the forearm. And then is responsible for sensation in the first, second, third, and half of the fourth finger on the dorsal side of the hand. Patient comes to you presenting these different signs but has no emergent situation happening. No spinal deformity, no acute trauma per se. Or maybe they do have acute trauma, but the neurological symptoms are residual and lasting a long time. Well, it might mean that they have something called an AMT. An AMT stands for an adverse mechanical tension. What this means is that somewhere along the nerve that we are discussing, so for example, the radial nerve, somewhere along the radial nerve, there is an adhesion between either the axon, the myelin sheath, or the myelin sheath within the fascicle, or even the fascicles within the epineurium. This is called either a crush or a double crush situation. Crush just means that there's an adhesion somewhere along the nerve pathway. Double crush means that there might be two adhesions happening within that nerve pathway. Crush and double crush injuries or adhesions can happen for a couple different reasons. If a person has had any sort of injury in the area of a nerve, it can be that while the body was trying to heal itself, it created those adhesions. Other reasons why symptoms might be provoked neurologically is because there's inflammation currently in the area of a nerve that's causing some sort of impingement and setting the body, making some sort of response, such as loss of sensation or weakness in muscles, that is an indicator that there's some sort of neurological pathology happening. So how do you differentiate the two? Besides history taking and understanding the mechanism of injury, you would run what's called a tension test. So I'm going to demonstrate a tension test and then talk about what a positive finding looks like. Diagnosing a tensioner somewhere along the nerve is really quite simple and can be done both in person as well as over telemedicine, which we'll discuss in just a moment. So remember, the idea is that we want to apply different tensioners to the nerve by using joint positioning. In order to do that, we need to take it segment by segment. As we strain the radial nerve or put a tension, like taking the cord and tightening it, we are going to ask at each step whether the person feels the same symptoms that they felt before. So, to perform the radial tension test, the very first thing that the patient is going to do is they're going to depress their shoulder, then they're going to wrap fingers around the thumb, internally rotate the shoulder, ulnarly deviate and flex the wrist, laterally flex the neck away from the test site, and then compare bilaterally for range of motion differences. Here's some pictures in case you're a visual learner. So the first thing that we are going to instruct the patient to do is we are going to make sure that they are depressing their shoulder. Well, usually this is done with the patient standing up. I just wanted to demonstrate that the patient is depressing their humerus away from their acromioclavicular joint and away from the glenoid fossa. The next thing that the patient's going to do is they're going to wrap their fingers around their thumb and tuck that thumb in, holding a moderate to tight fist to keep the thumb in place. After that, it is important that the patient keeps their elbow straight but internally rotates their shoulder, keeping the fingers flexed around the thumb. This is a combination movement. The next thing they're going to do is they are going to ulnarly deviate the wrist and then flex the wrist, keeping that thumb tight. Last but certainly not least, the patient is going to position their neck away from the tested side. Now remember, at each of these steps, each of these phases, you are asking if the person is feeling any symptoms. So, depress the shoulder. Are you feeling any symptoms? No? Then you take the next step. Wrap your fingers around your thumb. Does it make you feel any symptoms? No. Next step. Internally rotate the shoulder. Does that make you feel any symptoms? No. For these next steps, I'm going to take a step back so that you're able to see me a little bit better. So they've now wrapped their fingers around their thumb. They have depressed their shoulder. They're internally rotating. Any symptoms? No. Next thing that they would do is they would do a combination ulnar deviation and wrist flexion. Now, I personally happen to be feeling this here, so I would say that this is a positive test. But if your patient didn't have any symptoms, you would proceed to the next step, which would be to side bend away from the affected side. Now, again, it's important to compare bilaterally to see if there are any subtle changes between the two sides in range of motion. Now, getting back to what a positive test means, let's take a look. Now, before I move into the positive test, I do want to make mention that this is one of those tests that you are able to easily do over telemedicine. Of course, you'd have to adjust your instructions so that the patient really understands what you want them to do and what positions that you want them to be in. You also need to make sure that you are able to see the different positions and the abnormalities that they are presenting so that when you compare bilaterally. But other than that, this is a resource that you can utilize while engaging in a telemedicine encounter for people enduring neurological symptoms. So let's move back into what a positive test means. So a positive tension test means that in the nerve that you tested with the positioning that you use, the patient's symptoms were reproduced by the procedure and are changed by either adding or subtracting sensitizing maneuvers. This is why it's so important to make sure that you're asking the patient if they are feeling any symptoms. And if those symptoms are the same as the initial complaint at each segment that you are placing in a certain position. Now, that's not always what can be creating a positive test. Besides the adverse medical or mechanical tensioner, it can also be that the nervous system is already irritated or hypersensitive. So any position that you put it in is causing a neurological, is reproducing neurological symptoms. The other thing that could happen is the nerve is being pressed into a surrounding structure regardless of the adhesion. So be careful that you are making sure they're not doing any accessory motion and just really visualizing where that nerve is from the spinal cord all the way down into its distal insertions so that you can visualize what kinds of structures those things might be running into. Ultimately, what this comes down to is making sure that you are taking a thorough medical history to understand if this person is at risk for having any sort of adhesions within the nerve itself, or if they have incurred an acute injury that is putting inflammation somewhere within the nerve. In all, I hope this video has been helpful for you to understand what an upper limb tension test for radial nerve is, how a nerve is supposed to move, and what a positive test may mean. If you're interested in practicing other tension tests, please look for my suggested videos on an upper limb tension test for the ulnar nerve, or please visit my colleague Dan Waterman's video on an upper limb tension test for the median nerve. Thanks for watching.